Hi, everybody. Happy Diwali to everyone celebrating before we get started. My name is Shilpa Patel, and it is my pleasure to welcome you all to today's webinar, Fostering Partnerships to Address Racism and Disparities in Cancer Care, made possible with support from Genentech, a member of the Roche Group. Next slide. So over the next 90 minutes or so, we're going to hear from a number of different exciting presentations on both the need and the challenges to foster partnerships between community stakeholders and healthcare systems to address racism and disparities in cancer care and outcomes. We will start with an overview of the Learning Collaborative that brought together these important partnerships together and how the project team endeavored to set up a different type of learning collaborative in this opportunity. We will then hear directly from 3 of our partnership sites listed in the Learning Collaborative listed here. And then we'll close with the moderated Q&A where we'll have an opportunity to ask questions directly of our panelists. Next slide. Before we get started, I just wanted to go over some logistics. To eliminate background noise, audio lines are muted during today's event. There's going to be a moderated Q&A during today's presentation, and you can submit a question online anytime by clicking on the Q&A icon located at the bottom of your screen. Instructions are shown below on the screen at this time. And finally, a brief online evaluation will pop up on your screen following the event today, and your feedback is really important to us, and we hope you'll take a minute to complete this survey. Next slide, please. So in an effort for you to get to know us, we wanted to provide some information on our organization and the team. Next slide. So the Center for Healthcare Strategies, or CHCS, is a nonprofit based in New Jersey that works with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for children and adults served by Medicaid. Since 1995, we have worked in every state in the nation, and we partner with state and federal agencies, health plans, providers, community-based organizations, and members to make healthcare work better for people who face serious barriers to well-being. We at CHCS work to advance more effective models for care delivery, more efficient policy and program design, and across all of our work, we really focus on more equitable care and opportunities to address the obstacles that stand in the way of health equity for people who face the greatest disparities. Next slide, please. I also wanted to introduce the project team who oversaw the Learning Collaborative. So the team is made up of me, Dr. Dana E. Crawford, a pediatric and clinical psychologist. Dr. Crawford is also a scholar in residence at Columbia University Zuckerman Institute and the developer of the Crawford Bias Reduction Theory and Training, and serves as a cultural bias consultant with organizations across the United States. Jahira Sterling is a program associate here at CHCS. And I also wanted to note that we were fortunate to work with a number of other team members, both at CHCS and beyond CHCS as part of this team. In particular, Danica Richards, now at Genentech, others at CHCS, including Tricia McGinnis and Rachel Davis, and our Genentech team, Rajni Dronamamraju, Ryan D'Souza, and Elizabeth Hawkins. Next slide, please. So the next few slides will go through the project that Dr. Crawford, Jahira, and I work on together, co-creating solutions to address racism and disparities in oncology. Next slide. So the project, made possible again with funding from Genentech, brings together healthcare systems and community partners in what we internally call an inside-outside strategy, which Dr. Crawford will go through during her presentation. The partnerships come together to pilot new interventions at the community level that address racism and reduce disparities. In parallel, they work together to acknowledge and address the institutional racism and bias that have been maintained and perpetuating inequities in oncology-related care and outcomes for communities of color. Next slide. We are extremely fortunate to work with 3 amazing partnerships around the country in an 18-month learning collaborative to advance 3 objectives noted in the previous slide. These sites are the Chrysalis Initiative and the Cooper Health at MD Anderson Cancer Center in Philadelphia and Camden, New Jersey, Sierra Sisters and Fred Hutchinson Cancer Research Center in Seattle, Washington, and Jefferson County Faith-Based Alliance for the Advancement of Health Equity, and O'Neill Comprehensive Cancer Center at University of Alabama at Birmingham. I'm now going to turn it over to Dr. Crawford to further discuss the Learning Collaborative before we hear directly from our partnership sites. Dr. Crawford?
Thank you so much. Next slide, please. So greetings, everyone. I come to you from Manhattan, and I hope that wherever you are, that you are in a space of peace, and love and are feeling very connected. It is such a privilege to talk very specifically about the work that we engaged in over the last 18 months. And there's some core fundamental principles that we really want to stress in talking about this work. The first part is this work really strives, continues to strive to have an inside out approach. And what do we mean by that? It really is about zooming into this word partnership. So often we lean in spaces that I find are collaborative. And when we think about collaborations, it's usually two entities, individuals, organizations, or systems coming together with their own resources, and each of those having complete control over those resources and really making decisions quite independently. This project really strives to move to a partnership. And in a partnership, the resources are commingled, the decisions are interdependent. And that's what we mean by that inside or outside approach. Specifically, we aim to have intervention implementation while also having institutional change. We also wanted to center Black, BIPOC expertise and experience, and not in a performative way, like, yes, here are two, here are three people of color, a Black woman, an Indian woman, that work, I think, often can be very performative, where you have people of color as part of health equity work, but where's the power? And so we really focused on having a Black and people of color be part of the core team guiding the initiative. We also looked at sites that had BIPOC leadership in the community and in their healthcare systems. And then lastly, we really wanted to lean in on the expertise of others and not just our own and not just in the healthcare system by having an advisory committee with advocates and research experts, all women of color. So pretty profound. The next thing we needed to do was develop a shared language and an understanding across partners. We did that by using my training model, the Crawford Bias Reduction Theory and Training, CBRT, and had a series of workshops really focused on what are the ways that the socially transmitted disease of racism spreads within healthcare systems. How do we increase our awareness of that, investigate how it's showing up in our systems, and lastly, how do we reduce it? The next part of this is really about how I introduce myself today, which is person-centered and race-explicit language. Person-centered in the sense that we didn't start our meetings where we're asking people to check in about their task. Instead, we started our meetings and all of our collaborations and partnership spaces of the question of how are you coming here today? What are the successes and what are the challenges and the personhood and the human that is in this space with us today? We also very explicitly named a thing, and that thing is racism. Oftentimes we can conflate race and racism and what causes certain things rather than really naming. It's systemic, it's structural, it's implicit, it's explicit racism. And that's what we're talking about. We also wanted to have shared power. And as we talk about shared power and resources, it goes back to that point about the inside out approach. How do you shift from a space that so often is collaborative to moving to a space of partnership? Well, one of the things that we did is we were really explicit about the money, and all of the community partners received at least half of the grant funding. The next thing was about intentionality. Anyone who has done this work before knows that you write this RFP, you have this beautiful vision, the work is really great in the beginning, and then stuff starts to happen, right? And you have to make shifts and changes and not always sure when it's all said and done, why did we do it that way? A dear friend often says it's really important that we document our own history, that it really is our history. And so we use an intentionality tracker as our core team to document why did we shift things that maybe were originally the vision but did not work for the partnerships. One of the big things that we noticed in the intentionality tracker as we were shifting things is the importance of not only just tracking the money, but the decision of the money, the decisions that we make and how we connect, the decisions we make and the language that we use with each other and what impact that has. One of the big pieces was the decision to give 90% of the money at the start of the project so we could really support the infrastructure, allow for organizations and communities to hire to do the work rather than doing that on the back end where you get all this money where the work is already done. And the last thing we looked at was cross-disciplinary tools and resources. Now, there's a lot of research out there that looks at the ways in which we can collaborate, the ways in which communities and institutions can come together, but not a lot of research on partnership. And so we leaned into the work of Adrienne Marie Brown and her emergent strategy. We looked at social psychology and organizational psychology and being able to lean into spaces where change is happening, that we have to be very responsive to the work that we're doing. Next slide, please. And so some of the big lessons that we've learned in this project that was so focused on relationships, on team building, on the process, and of course, all the outcomes, right? What we've learned in this process is the importance of asking the question, how do we build partnerships when many of us have been trained in collaborations? I often think about the process looking like affiliations to collaborations, to partnerships, to mergers. How do we get there? And that requires us to examine everything, to identify what is happening, and not just what's happening in the institution, not just what's happening in the community organization, but what's happening in the room, in these meetings, in our partnered learning, in our communication with each other. And there were times where we had to ask the question of, is racism, is bias, is prejudice, is oppression, power, resources showing up in the very meeting that we're having as we are trying to undo this work? At times there were cultural, I would say, ruptures, definitely times in which we had to challenge our own socially transmitted disease of racism and how it was showing up in the work. And so I think the biggest lesson we walk away with is that no one is above this work. We all have to constantly and very vigorously be evaluating and examining the systems in which we have collaboration moving towards partnership. I'll turn it over to Jahira so you can hear more from our sites. Thank you.
Thank you so much. Hi, everyone. My name is Shahira Sterling, and I am a program associate here at CHCS, and I have the honor of welcoming our speakers for the panelist presentations. The first team to present are from the Chrysalis Initiative and MD Anderson Cancer Center at Cooper Health. I'd like to welcome Jamil Rivers, Plachette Wiggins, and Evelyn Robles Rodriguez, who will be joining later on our Q&A session. Jamil Rivers is founder and CEO of the Chrysalis Initiative, which was born from Jamil's experiences offering guidance to women on how to thrive with breast cancer, even as she was actively receiving chemo herself. Plachette Wiggins is the Health Equity Coordinator at MD Anderson Cancer Center at Cooper University Healthcare in Camden, New Jersey. She manages health equity research and community-based initiatives aimed to decrease cancer health disparities, address racism in healthcare, and implement health equity strategies. Evelyn Robles Rodriguez is an oncology advanced practice nurse at MD Anderson Cancer Center at Cooper in Camden, New Jersey, where she serves as Director of Outreach, Prevention, and Survivorship. In their presentation, they'll be addressing inequities in breast cancer for Black women, a collaborative model between community and healthcare providers. Without further ado, I'd like to pass it on to Jamil Plachette to present.
Thank you so much, Jahira. So honored to be here today to talk about our collaboration with MD Anderson Cooper. We were so appreciative to receive this grant to really kind of expand and quantify and follow and track our work and also the impact. And so the Chrysalis Initiative, we have a number of different activations where we're specifically implementing interventions to really address this specific challenge, which is Black women with breast cancer not receiving quality standard of care on that continuum of care, and really working to provide that coaching and navigation support, along with using the technology with BC Navi for care tracking, creating this team-based model of care, and then also working with our technology to reveal the blind spots, if you will, as far as that cancer care delivery. And so we worked with MD Anderson Cooper, and Flechette and Evelyn were our equity champions within the health system. And we established a team-based model of care. And so as we were integrated into the supportive services model of resources for the Black and all patients with breast cancer within the Cancer Center. And we found that there were specific unique challenges to these Black women that we were able to provide more thought partnering and support in order to help resolve some of those challenges quicker. And then also someone who is that trusted messenger to our coaches are trained on standard of care and also can weave all of those elements of cancer care together in order to respond to whatever challenges, ultimately increasing capacity for the team and really making sure that these Black women do not fall through the cracks. And so it has been insightful on what the unique challenges are specifically for Black women, also women who have triple negative breast cancer, specifically what the unique challenges are for metastatic breast cancer patients, and also some of those insights as far as specific age groups. And so we've been finding that with this patient workflow, connecting patients through this intervention and also tracking them within the care tracker, working with Flechette, Evelyn, and the rest of the team in order to really reveal those blind spots, talk about what that individual patient experience is, and what challenges do we need to intervene, and also just internally improve as far as processes in order to make sure that they're receiving the care needed and support so that they don't fall through those cracks. And successfully, we have, served the number of patients within this particular grant. We're finding that earlier that this intervention is provided, that the more supported and empowered that these patients feel. And also just having that information readily accessible and having the support of our teams, it's really a true collaboration where these women are well supported. And I have to say that the oncologists and the cancer care team at MD Anderson Cooper are great, but it just adds that much more level of readiness and health literacy and making sure that there are no omissions in the standard of care if those patients understand what resources are available to them with the MD Anderson Cancer Center team, and then also understanding what to expect and understand the implications as to why those treatment elements are selected. And it really has improved their outcomes as we continue to track them. And we're excited to just continue this collaboration going.
Hi, thank you so much. And I'm Flechette. I work at MD Anderson. Thanks, Jamil. Working with Jamil has been a true pleasure. I've learned so much each time I hear her speak. And wow. As Dr. Richardson said when she started, like this inside-outside approach is really key to move into the next level of addressing racial disparities. And one of the things that we've done in terms of looking at this is interview staff as a part of the assessment. And while we're still in the process of that and we don't have the results to report today, I think it's really important that our team is committed to this work, that there's been over about 20 interviews with staff to look at the health equity assessment with staff. So I'm really excited about that. And we've also done a number of focus groups. And what really works for us, what has been working in terms of referring patients to Jamil's coaching program, is having dedicated staff to be on site at the cancer center when people are in infusion or going through chemo, to refer them to the Chrysalis Initiative, and having someone talk directly with patients about what the Chrysalis Initiative does has been really important to us and actually helped with recruiting more people. So we're excited about that. And One of the things in terms of our work with Jamil, like when we start our meetings, and I just think it's so cool, like Dr. Richardson said, that we ask, it's truly a partnership. Like we really check in and talk about issues that are relevant, that are in the media today, or that are urgent. So it's really cool. And this project, I don't know if you can notice that my background also includes Weill Cornell Medicine in Brooklyn, New York. Simultaneously, by doing this project, I also manage Assist to Give Me Your Hand project, which is specifically for African American women in both Camden and also in Brooklyn, New York. And Jamil has spoken most recently at one of our Pink Table Talks. So this conversation that we're doing in terms of the inside-outside work, outside, externally, we continue to do community outreach, awareness, and education, help inform people of our services, inform people of the risk for breast cancer, and help get them screened. Internally, we're looking within ourselves to see what is being done at the hospital, what is being done at the cancer center that can improve health and wellness. And when Jamil did our call last week, it's it's the end of October, and we've been very busy with Breast Cancer Awareness Month. And I started the call saying that I'm tired, like physically drained, right? From we did weekend events, we did evening events, and then also tired because I've been doing this public health work for over 20 years now. I know it's hard to tell since I only look like I'm 20, but I'm just saying that 20 years ago when I got into this work, I remember saying that, although Caucasian women have a higher incidence of breast cancer, Black women have a higher death rate. It's 20 years later, and I'm still saying the same thing. And the incidence looks different now when we talk about younger African American women, but the outcomes are still bad. And that has a lot to do with discrimination, racial biases, and things of that nature. So I'm excited to work on a project that is, as Dr. Richard said, calling a thing. Like we really have to address the issue and make some better progress and look at some really, and that's one of the things I love about the Chrysalis Initiative, because we're not just calling a thing. We're giving it some resolution, some options for solution, and I'm excited to be a part of it.
And I know I'm excited about the results, and just if you think about the different women in the different age groups and, us really getting to know them and connecting them with coaches and, the resolution to some of those barriers, and even just, having that support, feeling overwhelmed. I must say, because we work with so many hospitals across the country, the MD Anderson Cooper team is really focused on that. I find that even if there is an oncologist that might not be giving the attention or explaining the implications as far as treatment or the stage, making sure that the patient has an understanding, the Cooper team is actually filling in that gap when it comes to the cancer treatment. But, of course, they can't be around the clock and available around the clock. So we're helping to really highlight in those areas where that additional support can fill in those gaps. But what's really great is that, now that we're able to hone in we found that a lot of the metrics were similar to the challenges across the country. So just, it's great if you have a great doctor, but it's still really important for patients to understand that they received the complete diagnostic workup, that we're almost trusting and verifying and validating the oncologist's work to say, okay, this is my individual type of cancer. Did I get the complete diagnostic workup? And this is what's related to my specific treatment and why it was selected, as far as all those characteristics in the stage. And then for them to have that buy-in in order to understand why that was selected, and to stay compliant with that regimen if they are having challenges with some of the side effects and symptoms, and just really thought partnering on accessing clinical trials, figuring out, now that they have this cancer diagnosis, how it's going to just deal with their day-to-day and taking care of family and taking care of all that comes into it, where the majority of Black women are the head of their household. And so making sure that even though that they have this new challenge to deal with, that they can still have that support needed. And what's great is that we find that we're really just helping them access the resources within the Cooper team. And then also just helping them with the partners that we work with nationally as well. And just constantly making sure that anybody that falls below baseline, that we're flagging that for the full team. And but really it's just making sure that they understand the implications of standard of care. And that's our position. We find that as long as Black women are receiving that standard of care and there aren't any impediments to that, those outcomes are going to be comparable to what we see in the general population in white patients. And that's been substantiated with the focus groups and also the data that we're tracking as far as care outcomes with this project. And so it just is really demonstrating the efficacy of this intervention and the way that we can continue to grow and expand as a solution that works, I think was a fantastic opportunity.
Yeah. I agree. Yeah.
So I think we can turn it back over to Jahira.
Thank you so much for your presentation. It was very informative.
Thank you.
So next, I'd like to welcome our next team, which are from Sierra Sisters and Fred Hutchinson, University of Washington, and Seattle Children's Cancer Consortium. I have the pleasure of welcoming next Bridget Hempstead and Catherine Ryan. Bridget Hempstead. I'm sorry. Bridget Hempstead founded Sierra Sisters, a breast cancer survivor and support organization, shortly after her own diagnosis. The name is rooted in African origins, Sierra, meaning knowing, and reminds us that knowledge is in fact power. Catherine is the Assistant Director of the Office of Community Outreach and Engagement for the Fred Hutch University of Washington, Seattle Children's Cancer Consortium. Through her leadership, the Office of Community Outreach and Engagement facilitates bidirectional community partnerships, research, and public health practice to address the cancer burden in Washington State. In their presentation, they'll discuss eliminating disparate outcomes for Black breast cancer patients. And as a warm reminder, please utilize the Q&A session at the end of the presentation. And with that being said, I'll now pass it on to Bridget and Catherine to present.
Thank you so much for that introduction. And it's a pleasure being here. Thank you for giving us the opportunity to share this important work and also being funded to do this incredible project. Thank you. Next slide, please. So what I want to talk about is the history. And we all know, however, for reference, mistrust between the Black community, medical researchers, and healthcare providers embedded in generations of lived experience results in Blacks and African Americans experiencing healthcare challenges. And of course, we have articles, there's movies, and also trainings behind the syphilis victims. However, historically, prior to the syphilis project, there has been horrific healthcare disparities prior to this, and slaves is using as property and not noted as being human. Next slide, please. Racism and inequity in healthcare for African Americans. Blacks, African Americans experience illnesses at a higher rate, have lower life expectancy than other racial and ethnic groups, are one of the most economically disadvantaged groups in the U.S. We've endured racism, bias, discrimination in American society for hundreds of years, and is justified by white counterparts, unfortunately. There's a wonderful article by Jamila Taylor. I would encourage you to have the opportunity to read that article. I'm going to pass it over to my partner now for the next slide.
Thank you, Bridget. So I just wanted to share a little bit of information about our partnership. Bridget reached out when the RFA became available to ask if Fred Hutch would be interested in partnering with her on this endeavor. And we were thinking about when was the first time that Bridget and I met, and it was in the early 2000s. So when Plachette was saying that she's been in public health for over 20 years, and she was just probably a teenager when she started. I'm right there with her. But just to give you a little bit of background, so Sierra Sisters is a nonprofit community-based organization here in the Puget Sound area of Washington State that really exists to transform the experience of Black people experiencing cancer. And our cancer center, the Fred Hutchinson Research Center, unites innovative research and compassionate care to prevent and eliminate cancer and infectious disease. Next slide, please. So the folks involved in this particular project from the Sierra Sisters organization, obviously Bridget, and she has brought on Tigist Abibi as the project manager, and it's been amazing to work with them. It's always amazing to work with Bridget, and Tigist is a new team member, and she's been wonderful. And then from the Fred Hutchinson Research Center, we've brought in 3 different sort of programs at our cancer center. So our Diversity, Equity, and Inclusion Core, which is led by Dr. Paul Buckley. The Hutchinson Institute for Cancer Outcomes Research, which is led by Dr. Scott Ramsey, and our Office of Community Outreach and Engagement, led by Dr. Jason Mendoza. And then just acknowledging that many hands make light work, and so many of our team members also involved in this work, Nikita McPherson and Judy Nelson and Karma Kreisenbach and Haley Pritchett. Next slide, please. So for this project, when Bridget approached us, she wanted to really focus on implementing something that we could do within the Cancer Center to fight anti-racism. And so for lack of a better name, we came up with the Anti-Racist Oncology Project, or the ARO project, as we call it when we have our team meetings. And the goal was really to work with our institutional partners and with Sierra Sisters to co-develop solutions that we can use to improve health outcomes by addressing bias and racism in oncology access, the quality of care, and the outcomes for patients. And Bridget proposed that we could do this through 4 different ways. First, to really look at facilitating interaction between the community and the healthcare system to build trust. Second, by looking at the barriers that Black women face and that prevent them from being included in research and clinical trials. Third, to really look at developing a call to action so we can improve that cancer care experience for Black women. And fourth, coming forth with a group of recommendations for collaboration to work on eliminating racism and disparities in oncology. And I'm going to turn it back over to Bridget to talk about how she's gone about leading this work.
Thank you so much, Kathy. First, I want to say that it's been 27 years working with Fred Hutch, and to bring this project to life has been incredible. Our project progress by objective to facilitate interaction between community and healthcare systems to build trust. Why do we do that? Because if both sides are not talking to each other and they're in their own corners, they're not going to hear the important nuggets that can come out of having conversation and also changing policies from the top. These check marks under objectives show things that are completed. Recruitment of survivors and caregivers for the cohort for this project. Fred Hutch Cancer Center launched an inclusivity and equity in research task force, which is really incredible and perfect timing for this particular project. Examining barriers, preventing the inclusion of Black women in research, clinical trials, We know that's a big problem because what happens in clinical trials are usually only conducted for white women or middle-aged white men. Blacks are totally excluded. So you hear voices all over the world, over the country, talking about including Blacks in clinical trials, but also dealing with the reality that clinical trials in the past and historically was very racist. Community conversations with survivors and caregivers. This is so important. Inclusion and equity and research task force in our working groups that we currently have. Thank you. Next slide, please. Our project progress continued. Develop a call to action to improve cancer care experiences for all Black women. Working with survivors and caregivers cohort to develop anti-racist bias mitigation educational toolkit. That's going to be incredible. We've recruited oncologists for the video interviews. Not one oncologist that we approached said no. Develop recommendations for collaborations to eliminate racism and disparities in oncology. Our recommendations report from Inclusion and Equity and Research Task Force. Next slide, please. Our next steps in dissemination to occur through Sierra Sisters and Fred Hutchins Cancer Research Center. We'll use the Anti-Racist Bias Mitigation Educational Toolkit to deliver trainings to healthcare providers. We will continue to ongoing dialogue to promote cancer health equity for Black and African Americans through collaborative events such as our annual World Cancer Day event that will be coming up in February. So I want to just take this time to thank you all for listening and also encourage you, if you hear nuggets within any of these presentations, bring them back to your team, bring it back to your community, because change starts with you first. Thank you very much.
Thank you so much for sharing that. That was super powerful. And as the world keeps progressing and more diversity, so hearing this type of work being done is just amazing to hear. Thank you so much for sharing.
Thank you.
And last but not least, we have our final team to present, who are from the Jefferson County Faith-Based Alliance for the Advancement of Health Equity and O'Neill Comprehensive Cancer Care, University of Alabama, Birmingham. I have the pleasure of introducing Monica Baskin, Reverend Robert A. Sellers, and Verlon Sally. A little bit about them. Reverend Sellers is the president of the Faith-Based Alliance for Advancement of Health Equity and a chaplain for the Jefferson County Sheriff Department. In 2004, Reverend Sellers became the 8th pastor of the historic Friendship Baptist Church in the Rosedale community of Homewood, Alabama, and also serves as a moderator for the Mount Pilgrim Baptist District Association, which is comprised of more than 136 churches. Dr. Monica Baskin is a professor of medicine and assistant vice chancellor for community health equity at the University of Pittsburgh School of Medicine and associate director for community outreach and engagement and health equity at the UPMC Hillman Cancer Center. She previously served as professor of preventative medicine and associate director for community outreach and engagement at the O'Neill Comprehensive Cancer Center at the University of Alabama. And lastly, Verlon Sally is vice president of community health equity for University of Alabama Health System. He seeks out and builds collaboration with internal and external partners to provide leadership, education, and resources that facilitate the evolution, development, and implementation of the organization's health equity strategy. In their presentation, they'll be addressing their project work on health and equities and prostate cancer care. And without further ado, I'd like to pass it on to Monica, Verlon, and Reverend Sellers to present.
Great. Thank you so much, Jahira. It is certainly our pleasure to be here to share just very briefly about our program. And certainly, like our colleagues before us, very appreciative to be a grantee for this very unique program. So next slide. So I'm going to start just giving a little bit of a background about what we're doing, and then my colleagues will pick up with their respective viewpoints from both the community partners as well as the health system side. And then I'll come back and mention a little bit about what we learned. So we know, for example, similar to other types of cancers we've heard from today, that prostate cancer is one of the leading causes of new cancer diagnoses and the second leading cause of cancer-related deaths, particularly among African-American men in the United States. Overall, African-American or Black men develop prostate cancer at younger ages, and they also have earlier transformation of prostate cancer to the more aggressive parts of the disease. So compared to non-Hispanic white men, African-American or Black men have 75% higher rate of newly diagnosed cases. They're at least twice as likely to die from prostate cancer, and they have higher rates, particularly in the state of Alabama and Jefferson County, which is the area that we focused on. So I think, overarching goals for us and the work we're doing, really was to, one, understand what were the barriers or what are the barriers and the facilitators to getting more African-American and Black men to get their prostate cancer screening, as well as to go for care. We also wanted to get an increased understanding around prostate cancer awareness and do more activities so that we could get more men to go in to get care, especially earlier on, where we know we can have more possible treatments for prostate cancer. And then lastly, we recognize that the issues around getting men in for screening are not just at the individual level, but there's some systemic level issues or institutional issues. And so the other part of what we focused on was trying to make sure that we could provide anti-racism and racial bias training to the oncology providers themselves. Next slide. And so I'll turn it over to my colleague, Reverend Sellers, to talk a little bit more about the Jefferson County Faith Alliance.
Thank you so much, and thank you for the opportunity to continue to serve and be a partner in this organization. Jefferson County Faith Alliance for the Advancement of Health Equity. It's a nonprofit organization including over 150 faith-based organizations and leaders dedicated to the advocacy of the advancement and of health equity and achieving the healthy outcome for all residents of Jefferson County, Alabama. And using church-based liaison, identified men for participation in the needs assessment survey and focus groups, and offer space for project and event meetings, and hosted educational activities and prostate cancer screening opportunities.
And Reverend Sellers, before we move on, would you talk just briefly about why your organization, was excited about this and wanted to partner with us?
Our organization was excited because I think education is so important, and we want to be able to be that avenue to minister to people, in this particular case, to the African-American men, to minister to the holistic person. And so not only the spiritual aspect, but also the physical aspect of the person, to try to have better and healthier men in our congregation, in our various churches, and to also educate and also break down barriers, and also the long term of mistreatment, mistrust, and down through the years of African-American men. I think one of the barriers that we've come up over and over again is how they are screened and how prostate cancer is determined. But as a result of this survey and as a result of this project, we now have another project that we're leading to a prostate screening at one of our churches, one of the health equity churches, that we're going to have a health screening for prostate and information coming up on November the 12th at one of our local churches, Greater Shiloh Baptist Church. And so this project has led into other things, into at least put it on the minds and hearts of those who have been affected, And through some own personal testimonies of some of the men that I know personally, they have taken a survey. As a result, they did go on further and get screened. Some of them have prostate issues and didn't know about it. So we are grateful for the opportunity to educate, inform, and make them aware. And hopefully and prayerfully this will continue on, because it is an ongoing process. It has to be an ongoing dialogue with the men, that we can make sure that they have the information, and that we break down barriers, and they don't have, and that we give out the right information to the men.
Great. Thank you so much, Reverend Sellers. Next slide, please. And so I'll turn it over to my colleague, Verlin Sally.
Hello, good afternoon. My involvement with this particular project was just I kind of felt like it was one of my responsibilities as Vice President of Community Health Equity. As said, when I was introduced, it is my responsibility to collaborate with internal and external partners. And this was actually one of the first opportunities I had to take on that role. It was shortly after I was hired as the Vice President of Community Health Equity. And in this role, I wanted to ensure that we didn't just try to tackle all these social determinants because we are a health system. There's only but so much we can do. So we want to be very targeted and make sure that we can demonstrate a measurable impact. So to do that, we need to focus on opportunities that may exist within our clinical data that we can intervene and have some type of influence. In many cases, they will have a social determinant connection, but our driver is measurable impact. So when Dr. Baskin approached me early in my role as Vice President of Community Health Equity, I saw this as one of those opportunities to have a measurable impact. There's so much data that has shown over time throughout this nation, as we all are on this call learning, that racism and prejudice find their way into healthcare, and therefore those that should get the care don't get the care. Or because of historic nature, those that want the care are hesitant based on things they've learned about healthcare throughout the past, or throughout, stories or parables that they were told. So it behooves me to involve myself in this project and collaborate with Dr. Baskin and the Jefferson County Faith Coalition, because it also provided me an opportunity to engage the community with those individuals that already had the respect of the community. It led to more opportunities for me to engage them with other projects, other surveys, for example, the community health needs assessment, and some other things that I want to bring to them that we have resources for internally to UAB. But specifically in this particular endeavor, the opportunity to use these training videos that some of our staff have created, and when I say staff, I mean attending physicians in other areas in the med school, they created, as you can see on the slide, 4 videos that address 4 different areas in nature. 15-minute videos. In my role as, again, VP, I learned that we can use these videos to resolve some of the issues in this grant or this research opportunity. So we're now trying to roll this out to members of the comprehensive cancer centers, meaning attending physicians and clinicians in our cancer center, to educate them on how to address African Americans or even other minorities in the communities and what their deep-rooted issues may be or perceptions may be when it comes to seeking care. And so that's what we learned in this project, or at least I learned in this project, and I'm looking forward for more opportunities.
Great, thank you, Verlin. Next slide. So, lastly but not least is the O'Neal Comprehensive Cancer Center. So at one of 51 NCI designated cancer centers, we really were very excited to lead the academic piece of this partnership and leverage the work for over 2.5 decades of community outreach and engagement in the state of Alabama in particular. And Jefferson County is the county where the city of Birmingham is and where the cancer center sits. And so certainly we wanted to make sure that we were doing things in our own backyard, so to speak, to address the grave disparities that we see in prostate cancer. Our role was to manage the financial resources, sort of develop the tools and survey and do some of the analysis, but certainly work with each of our partners there to roll out our survey and our focus groups, and to make sure that we were doing things in a culturally sensitive way. We also led the opportunities for cancer awareness and education, and partner with other groups that are in this space. So the Mike's Live Prostate Cancer Foundation, for example, is one of our leading partners, and we've been able to leverage work like this with other projects. The Urology Health Foundation is a nonprofit led by several clinicians who are out there and available to provide low cost or free screening in the community, as well as our indigent care facility, Cooper Green Mercy Health Services Authority, which is also targeting lower income individuals. So through those partnerships and through this longstanding outreach and engagement opportunity in the Cancer Center, then we were able to really gain a lot of information and get more people exposed to prostate cancer education and screening. Next slide, please. So just briefly, we were able to survey over 100 men, African-American men, average age around 56. At least half of them had no history of prior prostate screening, even though they were in that age where we would think that they would have a higher risk or at age for screening. Despite the fact also that about 40% of them had a family history. So someone in their family had prostate cancer, but yet they did not get screened. We also looked at their education, and about 44% of them scored, fairly low in terms of their knowledge and education around it. A third of them expressed that they had sort of high distrust of the medical system, which we've heard from each of the presentations so far that is probably a significant problem. And the vast majority, 91%, said that they themselves had experienced some type of discrimination in at least 3 or more settings. So work, community setting, and or healthcare setting. And 41% reported the highest level of exposure to racism as we evaluated them using a standardized measure. And just a couple of quotes there from the focus groups. Again, as Reverend Sellers talked about, a lot of the men were very candid about, not going to the doctor until something was really drastically wrong, having concerns around trusting the doctors, and still, those kinds of issues are playing a role in what we do. So next slide. So ultimately what we're doing, certainly as been mentioned, we're extending this work. Though I personally have left UAB, my colleagues and the people listed here are there and are doing fabulous work, under Reverend Berlin Sally's leadership, Reverend Sellers' leadership, and the leadership of the O'Neill Comprehensive Cancer Center. So we look forward to answering any questions if you have them. So I'll turn it back over now to Shilpa.
Thank you. Thank you so much, Drs. Baskin and Sellers and Verlin, for your presentation, and to the rest of our panelists for their presentations too. So I'm happy to move us over to the Q&A. And as a reminder, you can submit a question online anytime by clicking on the Q&A icon that's on the bottom of your screen. And while we are waiting for some questions to come in, I ask all of my panelists to please turn their video on and turn the audio on so we can engage in this conversation together. Thank you. Okay, the first question is actually for the community partners who are on the line. So I'd love to hear from Jamil, Bridget, and Reverend Sellers. What has been your experience in partnering with health systems to address issues like racism, like bias in cancer care and outcomes, which I know can be pretty heavy conversations? Any facilitators or challenges that you would share with the audience in kind of developing these partnerships or even engaging in these conversations together?
What's the conversation is? Go ahead.
I'm sorry, go ahead. Oh, no, I was just going to say, I think the initial challenge is that the disparities are caused by racism. So it's really unpacking that and presenting the data so that there isn't a rationale to explain it away or to attribute the challenges to, structural processes or breakdowns or chalking it up to blaming the patients, so to speak, as far as lack of education, lack of compliance, social determinants of health. So there's all these, rationales that pop up initially. And yes, there is, of course, structural racism that is coming into play. But a lot of times it's also provider bias as to why they're not engaging patients of color in the same manner that they do with the white patients that come through the health system. And so we see this demonstrated by body language, delayed wait times, taking the time to explain or answer questions, or making sure that that same patient-clinician communication and trust is established, and not just, not putting in the same amount of time and effort. And we also find some of those breakdowns come in maybe billing or administration or just navigating through the system. And so a lot of times when we're presenting this information, it'll be rationalized as, oh, those are just structural barriers or not attributed to racism. So it's hard to come up with solutions in order to address those challenges if we can't even have a consensus that it is caused by bias and racism in the first place.
She said everything I will say. But I did know that, and it was a challenge, but it was a challenge accepted to try to convey. I appreciate the opportunity to serve with our partner and being a partner, community partner. But it's a challenge to get the African American race to trust, because there's so much mistrust, misleading, and mistreatment that has taken place through the years that it has been passed down from generation to generation. One of the things I found successful in trying to help our African American men to even get tested or think about their health is to lead by example, and to stay on top of my health and advocate to them and be open, be transparent in my physicals and in my assessments and things that are going on with me, to share with them how important it is for us to stay on top of our health and listen to our bodies. So it's a challenge, and as I said earlier, it's an ongoing work, and all of us have to do our part in our own families and our own particular circles to try to make sure we relay correct and accurate information to help African Americans to make the best decision, regardless of the racism that we have endured through the years. Our health is most important, that we make sure that we get the information, ask the right questions, get the right information. If you don't like the doctor you have, you always can choose someone else. Don't let any barriers prevent you from obtaining what you was set out to do.
One of the things that I have always practiced and teach that with Sierra sisters as they go out in the community and dealing with healthcare systems, especially when there's talks involved, is reminding them of the historical institution that was built. Hospitals were not designed for Blacks. We weren't allowed to go to the hospitals that had the excellent facilities. It was already separated because we were not deemed as being human. So if we don't remind them where we came from historically, it's a lot easier for them to repeat the historical tragedy that has happened in the communities. So with that said, you cannot build a structure that will include and be equitable for the Black community if you don't have those voices there at the beginning of restructuring a really dysfunctional healthcare system. All the way down to the person who is scheduling appointments for individual are sitting there despising a Black woman because of the color of her skin, not even understanding why, because they've been taught historically that we are not valued as human beings within their white society. That's why we have to be very bold as Black individuals in their face, regardless how uncomfortable that makes them feel. 20 years ago, when I established partnerships with Fred Hutch, I couldn't come in shy and letting them say, oh, we don't have those issues and we're dealing with that. I had to call it out, and they agreed. And 27 years later, we still have an incredible partnership, and they're willing to do the change. And it's being seen there to create this change, not only for the research side, but also for the clinical side. So the voices have to come together. Researchers have to do research on African American. And for the community side, we're teaching about the real racial issues and these safety measures that are in place to change the way that they feel about being included in clinical trials. We're teaching them the questions to ask so that they can be empowered to be able to face their providers, the researchers, and the clinical trials that they may be able to endure in. So, thank you.
Thank you all. Yeah, you all noted themes that I think we've seen and kind of engaged in as part of this learning collaborative, the issues of boldness and innovation. I think we've really appreciated the boldness of your approaches, but also the ability and the openness to have those uncomfortable moments, those discomforting moments. So I've really appreciated your efforts in that area. Bridget, the next question actually touched on your last comment around clinical trials. So I might turn it over to you, but I know that Jamil, Dr. Basket, you are also doing this work as well. In that you had called out the racism in cancer clinical trials in particular. What have you all done to, in that area specifically, to combat the racism of cancer clinical trials? And Bridget, I'll start with you, but Jamil, Dr. Baskin, and others, please feel free to add in.
By working with the oncologists. So working with the oncologists and also the gatekeepers, which are our primary care physicians, to educate them to be able to share this information with their patients. And then also bringing up the issue of oncologists feeling like if we tell you about clinical trials, we're going to lose you as a patient, which means dollars and cents. That's money. And having them understand that they're still under their care, but a clinical trial could save this patient's life. And you're giving them more options to be able to navigate through a very complex, scary issue that they're facing as a patient. And also valuing their lives, that they're just as important as anyone else and to their family to be able to experience the best treatment options that are available for everyone. So if they're good for your white patients, offer them to your Black patients with the understanding and the information that needs to go with that, so that that patient can make an informed decision and that you're not making it for them. You're coming together as a team and building this relationship of trust.
We have a couple of different activations where one is during the planning phase, where we provide technical assistance to CROs and the sponsors of the clinical trials. So going in, the design is already built in, where we're thinking about how are we going to make sure that it's inclusive and has that cultural humility built in, you know, as far as who are they engaging with, who are they going, who is their day-to-day, who do they go with questions if we're not embedded into just the flow and design of the trial site. Also, what happens if they're not viable in the trial anymore? What support is there? Who do they go to for questions? Things like that. The time of day, how many, you know, transportation, out-of-pocket costs, all those things have to be built in initially. And so it's great if it's there on the front end. However, we're also pulled in after the trial is already established. So there's the support to patients where We're providing the just enrollment support, eligibility questions, coaching and navigating, okay, what's what. And we find that many Black women are told that there are no viable options or no clinical trials available to them when that's not true. And we also find we help patients process all this information to not just accept the clinical trial, because it's really easy to qualify for a clinical trial if you have metastatic breast cancer, right? So we also have to keep in mind, is the clinical trial that's being recommended to you, is it based off of your individual characteristics and your type of cancer? What is the validation for that treatment recommendation? Because we also find that some sponsors and systems are shifting Black women to clinical trials just to get those diversity numbers up, right? Because now the government is looking at that. They're saying, hey, it has to, your patient population has to be representative of the disease burden, and also has to be inclusive and have that demonstrated efficacy of that diverse patient population. So now if they find that certain, and the thing that's interesting also is that they're holding it as a carrot to say, oh, well, I know that you're interested in that particular treatment because of the evidence that showed that it's applicable to your type of cancer, but how about you try this one first? And if it doesn't work out, but we don't have time to play games like that. So we make sure that we're advising them on what clinical trials they should be prioritizing based off of their individual characteristics. And then of course it's pulling in the community health sites and partners in order to make that clinical trial more accessible. And then recruitment and enrollment, just to get this on folks' radar if the health systems themselves are not showcasing these clinical trials that are available to them. And then next year, we actually will have a clinical trial feed within BC Navi based off of the participants, based off of their individual data and subtypes and stages that shows them the clinical trials that they're available to enroll in their area.
Yeah, and I mean, I echo everything that my two colleagues have said before me. And what I will say is, I'll go back to Bridget's statement. I mean, you have to be bold. So both in my previous role as a senior leader in the Cancer Center in Birmingham, and then now certainly in a similar senior leadership role at UPMC Hillman, you know, we have multiple strategies. So at the individual patient level, a large part of that is having culturally competent educational and awareness, you know, activities so that people, before they even come in the door, they understand what a clinical trial is or is not. They get access and know where to find clinical trials. So we do a lot of education there. We also do a lot to assess, you know, what some of the barriers are to enrolling in a clinical trial. So whether or not it's transportation, co-pays, lodging, those kinds of things at the individual level. But then there's another level, and that's at the provider level. So as many of us have already talked about, you know, getting anti-racist and unconscious bias and other kinds of training to make providers aware that their stance coming into the room has a lot to do with who they will even approach about a clinical trial. So we see a lot about the disparities, but the research finds that when people of color are approached about a trial, they are just as likely to enroll in that trial as anyone else. But we know that there are biases where people don't even approach certain groups because of what their preconceived notions. So some of that is getting in their training, making them aware of it. And then there's another level, I think Jamil kind of touched on this a little bit as well. It's at the level of some of the pharmaceutical companies and really having them understand and taking advantage, I'll say, of this, you know, increased interest of theirs to make sure that their trials are representative and to talk about some of the barriers that exist. So oftentimes when you have communities of color and folks in rural areas, they don't just have one issue. It's usually not just cancer. They have other conditions, and a lot of times they're not eligible for clinical trials because of comorbid conditions. So part of what I've done, you know, in working with several pharmaceutical companies is, hey, and with our team, you know, we talk about which of these exclusion criteria can we get rid of? I mean, we certainly want those there for safety, but some of them are just artifacts and they don't really make a lot of sense. And so you don't have as many open. And then the last thing I would say, you know, as a senior leader in an academic medical center, is we've got to do more about increasing the diversity of our workforce. And so that's part of what, you know, as now an assistant vice chancellor at University of Pittsburgh, you know, that's what we're looking at. You know, who are our providers? Are they coming from the backgrounds of the people that we want to be enrolled in clinical trials?
Thanks all. Yeah, Plashette, I think you had started your conversation about saying like the difference between incidence and mortality as part of cancer clinical trials. One of my first projects in my long but short professional career, because I'm also young and lively still, was about recruitment and retention in cancer clinical trials, and the numbers haven't changed in almost 20 years, which is crazy too. Dana, I think the next question is for you. And it's a big question, I'll say, is how specific in the work, like what is the data that you're able to use to quantify provider bias, especially around areas of like preventing, I think, retaliation or kind of fostering understanding. So I'd love to get your thoughts on that.
Yeah, I'm probably going to partner a bit with Jamil on this as well. But, I have found that a lot of the assessments that have been done are very homegrown. So it often looks like an organization that has become interested recently or reinterested in diversity, equity, and inclusion. Before, it might have been multicultural training, before that cultural competency, cultural humility, whatever the current wave or language might be, that then come together and decide that they want to give some funding to analyzing their system. And then they create some type of survey. And then that survey is very homegrown, and it's hard to translate those findings into other systems. It's hard to really have any kind of longevity of data when those surveys are done in that way. And so I have found that one of the areas that I invite my colleagues in the field of DEI, DEIB, JEDI, whatever you're calling it in these moments, anti-racism, anti-bias, implicit, explicit, is to really think about what are some clear ways that we can assess the interventions that we're developing. There's a lot of efforts towards training, but there isn't a lot of pre-post analysis. And so I think when we get to those spaces where people try and rationalize and getting data in those spaces, I'm very interested in what makes people feel that they have to defend the very clear data that says this is racism. What makes a person need to defend that? And as a psychologist, I go to the space of people often defend when they're at risk, when they feel that something within them is being challenged. And I think many of our providers feel that their expertise, their medical training, their commitment to patients is being challenged. And so in a lot of the spaces that I work in, I invite people to recognize that racism is something, to go to Bridget's point, is historical. We're all infected with this thing at this point. And so saying this is racism is not an analysis of someone's exact whole character of a person. You could be a lovely doctor and have racist behaviors. Like both of those things can happen concurrently. And so I go back to the original question about how do you get data about defensiveness, about retaliation. I'm not sure if that's the best question. I think for me, I'm really interested in how do you get people in a space that they can accept the reality of what is being presented in front of them, and then engage in behavioral changes that save lives. I don't know, Jamil, if you want to add to that.
Yeah, we typically use the electronic health data to analyze the care outcomes. So when did that patient come through the doors and present with symptoms? Did they receive, all the standard national guidance as far as the diagnostic workup and the treatment recommendations? And then we talk about, just the individual health literacy of the patients, also the length of time that they're waiting for appointments, or, the delay from diagnosis to treatment beginning, all of those. So we quantify all of that as far as that analysis. And then we're doing a deeper dive, conducting focus groups, speaking with patients so that we understand what the standard operating procedures are just for the general patients and interviewing the white patients as well. And then once we're able to quantify that, we're able to then do a deeper dive and say, okay, are these structural breakdowns as to the reason why there's the difference in the care delivery and experience of the Black patients? Or is this indicative of bias in these different settings as they go through that continuum of care? And once we're able to do that, it's really just presenting the data and stating, okay, these are the contributing factors. And when it's related to bias in that care delivery, and the bias, it's one of those things where if that is impacting the care delivery, which we're dealing with people, so there is going to be some bias, and unpacking that and understanding that there have to be some also levels of accountability. And so if that's the case where ultimately most health systems, especially if they're working with us or they've called us, they want to provide equitable care to all patients. So what is it that is impeding in that process? And so really work with them in order to reveal those blind spots as to what it is. And if it is a practitioner or a provider that is having bias in their assumptions and it's actually impacting the care and information that's being delivered to the patient, how is it that that is checked or addressed, or that there's some accountability put in place so that they don't have the autonomy to do that?
I see that these healthcare systems, unfortunately, there's a power dynamics that's there where if that doctor or researcher is in a very high position and they continue to behave in this manner, there's no consequences for them. The healthcare system has to develop consequences and no bullying attacks. When you're in schools, it's like, it's not tolerant. It's not tolerated. Violence is not tolerated here. You'll be expelled. You can't come back to school. Why isn't the same thing in place for healthcare systems that are killing patients? Once they're dead, they can't speak from the grave. They can't go and get an attorney. And if they are alive and they experience this before they die, they're too sick to be able to fight these very, very powerful white systems that are in place. I think it's beautiful that we have those systems in place, the check marks. However, there also needs to be consequences, very severe consequences, in treating human beings in this way.
Thanks, Bridget. Yeah, I think I've always appreciated, Jamila, in particular, your data-driven approach, but all across all the partnership sites. But I think that accountability that we've always engaged in conversation around, like, what do you do with that data when it's uncovered? What's going to happen, and kind of how are you being held accountable to the data? So I think we have time for one more question. I know I'd invite Kathy Plachette and Verlin in particular to answer that, if that's okay, because I think it speaks to some of your positions at your health systems. But the question came about the Office of Community Outreach and Engagement. So one of the participants is in a brand new position, and their office is brand new too. But their catchment area is their whole state, which can seem a little difficult in terms of how do you work within those conditions. So what are some first steps you can offer? But I would also add to that, in the work that we've engaged in and other work that I've engaged in, I've seen that this Office of Outreach and Engagement is often the first step for building community partnerships, or the first connecting step between health systems and community partnerships. So it also asks, what are the first steps you can offer, but also how can that office be leveraged to foster the partnerships that we've engaged in as part of this learning collaborative? So Kathy, Plachette, Verlin, I don't know who wants to start, but would love to hear from you all.
Hi, I'm Plachette. I'll start. I think one of the first things is coalition building. Who else is doing the work, finding out what else is being done, because what I find in public health a lot of times is that there's a lot of reinventing the wheel. There's a lot of repetition. So if this is a new office, this is a good time for you to go out and find out what else is happening, so that you won't reinvent the wheel, so that you can find good partners, because I'm sure they're out there and maybe no one has even ever asked them to partner before. So this will be a good time to find out who is already doing the work, what are their goals, and then also who has the ability to do the work but isn't doing the work because maybe they're not aware. and maybe you can invite them to be a part of the conversation. I think that Verlin said earlier, as from a healthcare perspective, we can't address all social determinants of health. So who else should be at the table? Who else from social services? Who else, from housing or different things should be at the table as well? Because addressing racism in healthcare can't be done by only the hospital or only the community partners that we collaborate with, but it has to be a collective in terms of looking at everyone. And I work on we're talking about cancer, but as Dr. Baskin said, people have heart disease, they have diabetes. So not to see the work in a vacuum, because when I go into Camden City, I know that I'm going in to talk to a group of people about cancer, but they also are addressing housing issues, crime issues. Maybe they have diabetes and heart disease. So who can I partner with? Who can I collaborate with to bring information on all of these things? Maybe it's not always going to be at the same time, but we can figure out a way to work smarter, not so much, harder, like that we can be more effective for the people we're trying to engage.
And for me, my advice, I did type up an answer, but I would say everything Ms. Wiggins just said is apropos to what I'm going to say. There's no one answer to this. There's no blueprint to this. So I would say, look into your data and find your opportunities there. By looking in your clinical data or even by your state data, and I listed some places where you can find those rankings. Robert Woods Johnson's foundation. You can go to your state health department and you'll find the opportunities that exist of where's the high prevalence of diabetes, where's the high prevalence of heart disease and so forth. And that could lead you to who you partner with or what collaborations you build. But again, this work can happen simultaneously. You can build partnerships out the gate and then do the clinical research and find out why I should be engaging in these partnerships. So there's no one answer to this, but just know, and this is how I felt about, when I started in my role more than a year ago. There's no blueprint, one. Two, there's no wrong answer. There's no wrong starting place. So wherever you're starting now, just keep in mind that you're never going to be the sole solution. You're going to have collaborations and partnerships and share data amongst those different sources. She's going to be quiet right now, but call Dr. Baskin. She has done this before. Even before I got started, I used a lot of data that she had already did the research on. Going back to what Ms. Wiggins said, you don't have to reinvent the wheels. Some of this is already out there for you.
I think I'll just add ditto to everything that Plachette and Roland just said. Our catchment area is also the whole state, but that's just a recent thing that happened. It used to be 13 counties in our state. And so as we think about how can we partner in coverage in the rest of the area, yes, looking at the data, and just start talking to people, have patience because it will take time. And when you talk to somebody to hear about what they're doing and what they see as the facilitators and barriers in the community, also ask them, hey, is there someone else you think I should be talking to, and use that sort of snowball effect to, cover lots of ground. But I will say, just to recognize that it takes time. So just be patient and don't come with your own agenda. I think by bringing that data from, across chronic diseases and different issues related to the social determinants of health, just being open and meeting the community where they're at. Because maybe, they're not ready to work on cancer first. There's lots of other issues, as Plachette mentioned, housing, food insecurity, income that, they may need to address first before they think about cancer screening because they're trying to put food on the table.
Thanks all. So I'm gonna call an audible, and I'm gonna say one more question. So I would love to hear final thoughts from all the panelists. Any reflections or words that you would share with the audience as they either embark on or are trying to build their partnerships across health systems and communities in the area of cancer. But I think, as we're all saying, this work is beyond cancer, right? Within the area of health, within the area of thriving and of life. So I'd love to hear from you all. Just any closing reflections or any thoughts. And I'm going to start with Dana, if that's okay.
Yes, it is okay. I think the biggest thing as a takeaway, I'll give 2 points. Number one, I think, where do you start? You start where you have the energy. So many times someone else is driving an agenda in this work, and you will burn out. You will burn out, you will be crispy. Follow the energy. The other thing is this work ebbs and it flows. It's like ocean waves. It comes in, it comes out. Be willing to change and adapt, because racism, I say it's like a Mighty Morphin Power Ranger. It changes so much, so rapidly, and to be willing to change with it, like even that what we call it. And so I think, go with your energy and adapt.
Thanks. Jamil, do you want to go next?
Yeah, I would say my biggest takeaway being engaged in this work is that we have to have more accountability. I think that's ultimately the biggest thing, because even if you think about just the regulatory requirements in order to get that equity credit, if you will, it really is checking off the box. So I think we need to tie it to actually care delivery and outcomes. If they're continuing to be substandard, then you should not be receiving all this equity credit. And we can't just attribute everything to poverty, lack of insurance, and social determinants of health. And so we need to address the fact that, in particular with breast cancer, when education, access to insurance, and income are the same, that these outcomes are still reflective of disparities in this space. And so we can't just continue on with the status quo. And so I love the opportunity with the Advancing Health Equity to pilot some of these interventions, so that it's more so taking the data as to what the evidence-based interventions and research indicate, and really having the teeth added to that, so that it's not just something that's nice to have, or maybe we'll do this, but really think about how can we ensure that equity is built into our care delivery.
Thanks, Jamil. I'm going to go through just the order of the boxes on my screen. So, Reverend Sellers, any closing reflections you would share with the group?
Yes, I think, of course, I was honored to be a part of this, but after doing the survey and the research and dealing with our various churches and our organizations, if anyone is going to embark on this, you have to be patient. Be patient with your community. You have to have good communication, and you have to have great commitment if you're going to do this. It's not a sprint, but it's a marathon, and it's not going to be fixed in one day, but you got to be committed to the work.
Thank you. Kathy, do you want to go next?
I think I'll just really commend the CHCS for really making this grant opportunity focused more on the community side, as opposed to, like NIH funding, where it always goes to the academic institutions. Because in this case, Bridget has really driven this project, and it's been wonderful. And I think our institution has really appreciated having her voice amplified as a result of this project. And people, people always listen to Bridget, but the timing was just right for us with everything going on within our institution and this funding opportunity. So there's definitely changes that are coming about because of it.
Thanks, Kathy. Bridget, do you want to go next? I feel like Kathy set you up really well.
I want to say that when you come in thinking that you're going to just come in and get the work done and it's just going to be easy as I don't know what, be ready to go to work and think about this. This is hard work. It may be hard work, but if you're doing it from the heart, you're going to make a difference and you're going to save lives in the community. You have to be honest. And there are going to be some very hard and difficult, challenging times. But don't let that bring you to the burnout stage. Be honest with yourself. Take time to do self-care while you're doing this work. An empty cup cannot fill anybody. You have to fill your own cup first so that you can fill other people's cups. Help them to get that overflow that you have. And you can't do the overflow if you don't take care of yourself first. There's blueprints that are set and ready to go. We just have to continue to till the ground so that it will bring fruitful nourishment to our communities and to the healthcare systems that are so broken.
Thanks, Bridget. Okay, so Verlin, Plachette, and Dr. Baskin in the last minute or two that we have. Verlin, do you want to go?
Sure, I'm gonna take the whole minute, so no. I just like to say thank you to the CHCS, first of all, and Dr. Crawford as well. Being a part of this initiative has been inspiring. But I just want to say this may be not to this group, but to someone that needs to hear it, that the window of opportunity that we talk about because of social injustice and the pandemic is not real. This is not a window of opportunity. This is just the work that needs to be done. So I'm going to say that. And secondly, we need more leaders in this space. To be a leader in this space, you have to have empathy, competence, and wisdom. That's it. It doesn't require a vast level of knowledge, but that empathy, the ability to want to connect with people and do what's right is what we need. And I'll yield.
Hi, I also want to say thank you to you guys for doing this work and to all the other panelists. And I think searching for common ground is really good. I love what Bridget said about this is hard work. So find like-minded people and also find people who may not be so like-minded, but they're doing the work anyway. So this idea of holding people accountable and holding ourselves accountable, being aware of our own biases and understanding how and keep the people at heart. Like, why are we doing this work? Why is racial disparity, health equity even important? And why have we chosen this field? Like really always examining your why and how can you help someone else? I think those are my takeaways. So thank you.
Yeah, and I'll just wrap up by pushing more on that. I think for me, it's about having true, authentic partnership. And so when you have that authentic partnership, then you're going to be connected. You're going to lean on one another. So it's not so hard to go, alone. You can certainly do it together. I think that's really important. And, a challenge to my colleagues. So as an academic, oftentimes, you hear people going out to get a letter of support for a grant or something else, and it's not true and authentic. It's not sharing resources and sharing the power that we've talked about here. So that's my parting word, is that it's a little bit lighter load when you're doing it together, especially when you have true partnership.
Thanks all. So in the slides that Emma had shared is my contact information if you have any questions about this project or about the organization. But I will just end by saying it has been a true privilege in my professional career to work with you all in this important work. And I look forward to moving forward together. Bye all.